Yes, hello everyone. So this is Basil, and John Snowden is self-isolating quite appropriately for this talk at home, and he's on the phone, so he will speak. He'll speak to us as well. So I've been asked and John to speak about AHSCT in the era of COVID-19. And the question really is whether we can use stem cell transplantation to treat patients with multiple sclerosis. And the answer, as you can see from the slide, is no. And you can take my answer, my face expression as an answer, or really sort of the long version that John is going to explore with us later on. So at one stage, stem cell transplantation was quite really thought to be a game changer in treating patients with severe relapsing, remitting inflammatory multiple sclerosis. Really, it's a treatment for patients who have either highly active relapsing remitting multiple sclerosis or rapidly evolving severe multiple sclerosis. But also at some stage, we thought it could also be used for those patients who have aggressive type of MS, even if the illness is very active before they failed standard disease-modifying treatment. Obviously, we treated patients in the relapsing, remitting, inflammatory phase because the treatment is not that effective in the progressive phase of the illness. And the question really was to assess its efficacy in relation to the various therapies available to us, including agents which can modify the immune system, including interferons, glutamate, dimethyl fumarate, etc., or those agents which will modify the lymphocyte trafficking, including natalizumab and fingolimod, or those patients which will deplete lymphocytes, including ocrelizumab, alatuzumab, and cladribine. But of course, the beauty about using stem cell transplantation is that if the immune system is not behaving, then perhaps replacing it with a novel immune system might resolve the issue. The way really to assess the efficacy of any of the therapies is now to look for so-called NEDA, no evidence of disease activity. And if you look at this graph from a paper published by Pablo Morore, you could see that at 2 years, NEDA figures for the majority of agents were quite good, up to 50%, but really not as good as those figures related to use of stem cell transplantation. These are all cohort data from cohorts rather than clinical trials, but you can see that the worst you can get really at 2 years is a NEDA of about 70%. And then NHS England produced the guidelines in terms of how we treat patients with multiple sclerosis, and stem cell transplantation made it to the algorithm, but really as a third line treatment, as you would see. So a patient would need to have failed first and second line therapies to be eligible to be considered for stem cell transplantation. The treatment, however, is very attractive on economic grounds as well. Here's our figures in terms of how much it will cost if you treat our patients with various agents, and compare that to a one-off cost of about 30,000. So it's not recurrent cost as one-off. So it is quite really attractive way of treating patients on economic grounds as well. Perhaps John can take over to talk about the treatment itself, if that's okay, John.
Okay. So this is an intensive treatment that's cross-fertilized from hemato-oncology and really involves chemotherapy and anti-thymocyte globulin and stem cells. And you get the stem cells, as you can see in this picture, through apheresis, and you get hold of those by a combination of cyclophosphamide and GCSF, and then donors go onto the patients go onto the machine, and the stem cells are collected and frozen down, and then the patients get admitted. Let's go to the next slide. They get admitted after been mobilized and the stem cells have been collected, they get a high dose chemotherapy regimen, which is usually cyclophosphamide and antithymocyte globulin, and in some countries it's BEAM, which is a lymphoma regimen combined with antithymocyte globulin. They then go into this aplastic phase where they need supportive care with transfusions of antibiotics and transfusions and antibiotic treatment, and are tided through until they engraft about 2 weeks, and then they have a further few days where they recover as an inpatient, and then they're out into the outside world where they're usually stable, but they're often immune suppressed for many months, you could say, when it's been looked at in terms of cell subsets. So this is relevant to this talk in terms of COVID. I'll just go to this next slide. Just tells you that the process is regulated by various agencies like JC and the Human Tissue Authority. I don't think we need to dwell on that too much. And I'll hand back to Basil, who led the EBMT guidelines for multiple sclerosis and immune-mediated neurological diseases. These are from the EBMT, which is the European Society for Blood and Marrow Transplantation, which is a very big European organisation bringing together all elements of the transplant community. But we have a working party which focuses on immune diseases, non-malignant diseases, which is in a contrast to a lot of the other working parties because they're focused on leukemia and usual indications for stem cell transplantation. But we do cover MS, and MS is the most common indication for transplant. I'll just hand over to Basil now because there's a few slides that come from the EBMT.
So everybody who received stem cell transplantation for multiple sclerosis in Europe, the details went into the EBMT registry, and you can see really that since 1995, the number of patients treated have been escalating gradually. And you can see really that Italy is leading Europe in terms of the number of patients treated, and United Kingdom is second behind Italy to that effect. But really very important to say that the evidence so far in terms of efficacy of this treatment really come from cohort studies rather than clinical trials. The only phase 2 study to assess efficacy of this treatment in MS is this study, and that is a study which looked into 25 patients, mainly with progressive rather than relapsing remitting disease, and compared the efficacy of mitoxantrone against stem cell transplantation. And the study had to be terminated a little bit prematurely because of lack of recruitment, but it did really reach a primary outcome measure, and you can see from the graph that so those patients received stem cell transplantation in terms of looking at MRR scan activity did significantly better than those who received mitoxantrone. Note that treatment-related mortality was 0. And then this is probably the second or the largest cohort of patients treated in Chicago, 145 patients, mainly with relapsing disease, and some of those failed standard treatment, and then they were treated with cyclophosphamide and ATG, so this is not a myeloablasive regimen, and then followed up for a number of years. And again, not that treatment-related mortality was 0, but really those patients were relapse-free. In about 80% of those patients were relapse-free at 4 years, and progression-free of about 87%. And for the first time, really, you could see that this treatment proven to be quite effective in terms of reducing the level of disability, a drop of an EDSS of about one EDSS point, which is quite significant. But this is a cohort study, so there's no control arm. And then similarly, these figures were replicated by a cohort from Sweden. And again, you can see really that in terms of efficacy, it was very much similar. It was noted that those patients who had relapsing remitting rather than progressive disease, those who had active disease on MRI scans did far much better than those patients who had long illness duration, and they were more disabled and did not have active MRI scan activity on imaging. But what was required really is data from a phase 3 randomized trial to prove all these observations. And that was the MISS study, which was run led by Richard Burton in Chicago, with sites in Sweden, England, and Basil. And really, the observations from the cohort studies were replicated. In that particular study, 110 patients were randomized to receive either standard treatment. Those patients had active disease and failed standard therapy, or stem cell treatment. And they were really randomized to receive any disease-modifying treatment deemed by the neurologist to be the most appropriate treatment, apart from alentizumab and ocrelizumab, because they were not available at the time. And you can see really that the figures very much replicated, as I said earlier, what was observed in the large Chicago cohort. But what was required really is a study to assess efficacy of stem cell transplantation against alentizumab or ocrelizumab. And that was a study that we've been planning to run in the UK. And the study was supposed to start in a few months' time until COVID-19 became a major player. Now, that was the UK study, but there were similar European studies really addressing similar questions in Norway and in Germany and Italy. And all these studies are now on hold. Now, Gavin recently gave a webinar where talked about the ABN guidelines in terms of using disease-modifying therapies in the COVID-19 era. And you would recall really that the agent that we were trying to compare against stem cell transplantation, alentizumab and ocrelizumab, are no longer felt to be safer therapies. And certainly stem cell transplantation itself is no longer thought to be a safe therapy for those patients. So this trial is on hold for now until we recover from the pandemic that we have at the moment. So I think we've been learning about COVID-19 and over the last few weeks, and as we all know, this is this novel illness which started in China and since affected the whole globe, and this is really an illness which often present with fever and cough and shortness of breath, and patients often complain of muscle pain and sputum production and occasionally diarrhea and sore throat. And the majority of people would have a mild illness, but some patients will have severe disease and result in multi-organ failure. As of recently, the mortality rate was about 4.4%, ranging between 0.2 and 15%, depends very much on who is being affected. And the virus, as we know, typically would spread during close contacts via respiratory droplets when affected patients cough or sneeze. And these droplets can also be produced during breathing, but this illness is not considered to be an airborne condition. But the droplets will affect various surfaces, and when patients touch these surfaces, and then subsequently their face and their eyes they become affected. And most people became contagious when they are symptomatic, but some patients will spread the disease before the symptoms develop. But the virus can live on the surface for about 72 hours, and then the symptoms will start within 2 to 14 days from when when individuals get affected, but the average is about 5 days. The way that individuals are diagnosed with this condition is a PCR from a nasopharyngeal swab. And then many patients, you could make the diagnosis in some patients based on the clinical symptoms and risk factors and a CT scan results indicating features of pneumonia. The recommended measures to prevent the infection include frequent hand washing and social distancing and keeping hands away from the face. It is the use of face masks is recommended for those patients affected and for some of their caregivers. Some interesting facts, learning points. So the patients become infectious within 12 hours of symptom onset, from the onset of symptoms. And the time from exposure to the onset of symptoms, as I said earlier, is probably around 5 to 6 days. And the patients will recover within 2 to 3 weeks. And those patients who sadly die, they die within 2 to 4 weeks. And then the patients will no longer become infectious after 7 days from the onset of symptoms. There are very few patients who are asymptomatic. And in the majority of cases, 80%, the illness is very mild. In about 14%, the patient will have severe disease, and very small proportion of patients, 60%, the illness will be quite critical. As I said, fever and cough are the common symptoms, and shortness of breath is an indicator of severe disease. The risks really for severe disease include age and multimorbidities and immunosuppression, and that is very important in terms of this talk. Not certainly pregnant women are at increased risk, and I think the Royal College of Obstetricians will be producing guidelines soon. But important risk factors including hypertension and cardiovascular disease. The illness quite often is very mild in children who may spread the illness but have very little symptoms. And ARDS is the main complication of the severe disease, and patients can have septic shock and DIC, but this is less common. Lab markers which will indicate poor prognosis, including a high troponin levels. There are a few clinical scores which will indicate poor outcomes, and the CT scan of the chest quite often used to indicate that as well. The illness really is spread very, very rapidly. So one affected individual will be able to affect three persons, and then that will escalate. And the modeling which were done in Imperial College really sort of shaped really sort of how we're dealing really with this illness, particularly in the UK. And it's likely that there will be another wave of this illness perhaps sometime next year. The treatment is difficult. There's no specific treatment. It's mainly supportive therapies, but some antiviral agents and chloroquine and IL-6 inhibitors are currently being used in clinical trials. Of course, there's no vaccination, although many institutions are working on that. And the intervention really is now is done in the UK through clinical trials. Steroids is an issue. It's important for the use of for treating patients with multiple sclerosis, but you can see from this slide really that its role in similar epidemics, SARS and MERS, was associated with probably poor prognosis, and it is really sort of advisable, therefore, that at this stage steroids should not be used unless really it's very needed. Certainly, they should not be used outside COVID in the treatment of people with multiple sclerosis, because many of the relapses will probably settle down on their own. And if patients are on steroids treatment and they contract COVID, the outcome can be quite significant. So there are risks attached to the stem cell treatment. John, do you want to take over from here?
I think we all know that the autologous stem cell transplant treatment is at the very high end of immune modulation, immune suppression. It has to be intensive. It's not ongoing. I mean, one of the advantages is that it doesn't require ongoing administration compared with so many other MS treatments, such as even alemtuzumab requires that, requires repeated dosing. So the aim is really to produce a short, sharp shock to the immune system that helps the autoimmune diathesis reset itself. However, in doing so, there is a degree of immune suppression and risk, and potentially tissue damage and so on. So we have to accept that it is a much higher risk procedure in the short term than most other MS treatments. And therefore, I don't think it's too difficult a decision to say that we shouldn't be doing these transplants during the COVID pandemic. And I produced a number of guidelines and so on to say that, and I think everybody agrees with them, that we should wait until the pandemic's passed. Because we don't want any mortality in patients with chronic disabling disease like multiple sclerosis or any other autoimmune disease, because we're aiming really to improve quality of life and reduce disability. Very few MS patients have got immediately life-threatening prognosis, so we can defer it to a later stage in the year when we're clear of COVID. I think you've got the other side of the equation where you've got patients that have had the transplant. You know, I don't know how many patients we've treated in Sheffield as a whole, but it's probably between about 60 and 80 in that region. And I think that, and then the very significant numbers have been treated in London as well. But I think we'd all agree that it's important not only to defer transplantation, but to watch out for the patients that have been through the procedure, particularly in the previous year. So we've been advising our patients to self-isolate and take all the relevant precautions, because we feel that they would be significantly immune suppressed, particularly in the previous year if they had a transplant, but maybe even beyond that. We don't know that the immune system returns back to normal. And of course, we have been treated in the past with other agents, other MS, including steroids. So I err on the side of caution and encourage rigid self-isolation as much as is feasible. So we obviously want patients to avoid contracting any other respiratory viral infections such as flu and RSV, which can be quite destructive, but particularly don't know how patients are going to handle COVID, and therefore we should get a side of caution. So, Basil, do you want to go on to this slide from the webinar you attended?
This is data, thank you, John. This is data from EBMT, and to date, 15 patients in Europe who received stem cell transplantation have been affected by COVID, and 5 in Spain, and 2 in France, and 2 in Belgium, and 3 in Italy, and 2 in Sweden, and 1 in Greece. And sadly, one of these patients has died, and the others, I don't have data in relation to the health status of the others. And there are some...
Basil, that we don't know whether any of these were MS patients. They're more likely to be the broader population, aren't they, of leukemias, myelomas, and lymphomas?
Indeed. In fact, 12 patients had allo transplant, and only 3 had auto. And I don't know if any of these, of course, MS patients don't really receive allo transplant, they receive auto. And I don't know if any of the 3 patients had multiple sclerosis. Anyway, there is now an EBMT survey, and any patients who received transplantation and contracted COVID, the details really is being collected. So like John has said, really, those patients received stem cell transplantation within 12 months of the transplant probably should self-isolate, and we don't really know quite what advice we should give really, so beyond the 12 points, beyond what really everyone should follow in terms of national guidelines. But if patients after that develop any symptoms, I think should be tested immediately, and nasal swab should be taken, and just really sort of to remind myself that the nasal swab can be negative. So if the suspicion that somebody has got COVID with negative PCR swab, that should be repeated again. And if there's any suspicion that patients might have the illness with a lower respiratory tract infection, they need to have appropriate imaging, but really treated appropriately thereafter. Bronchial lavage is not thought to be really recommended or safe for those patients unless the appropriate clinicians treating those patients think that there might be another pathogen causing the symptoms. And then, John, we've come to the slide about restrictions for those patients. Do you want to take it over?
Okay, so, well, we just need to encourage self-isolation and as many hygienic routines and so on in those households where they have patients that have had HSCT for whatever reason, but particularly, it's important with MS patients. There might be aspects of disability and other things that mean that they're prone to more infection. And sometimes they may need carers to help them, and they might have close contact, unavoidable contact with carers. Avoid non-essential travel, and I think the other thing to say is this whole area, as many of you will know, is perhaps unfortunately complicated by a lot of patients referring themselves to overseas units. I'm not going to say anywhere specific, but they're often outside of the system, and it's not often the patient's fault. They're vulnerable, but they're often outside the haematology department system that most transplant patients, including all our MS patients, are under a firm mantle, a firm umbrella where they can access care for fevers or breathlessness very immediately. If people who have got genuine problems with their MS go overseas, then those links are often lost or never even set up in the first place. So there may be patients who've received HSCT abroad who may come your way, and we've always had the view that such patients shouldn't be treated judgmentally, and it's hard sometimes to criticise patients for paying their own costs for transplants or even raising money. It's often in the news, but people are often vulnerable and don't always get the best information. But it's quite possible that some of these patients who won't be under the direction of a haematology department will come in through A&E or come into your neurology departments. There may still be patients of an MS specialist in a neurology department, whether that specialist has been involved with any of their care recently or not. So be aware that there will be some patients that won't have the fast track into haematology. Certainly all of ours in Sheffield, they're very much under the safety net of self-referral at whatever stage they have any problems. So that's one thing to mention. And I think probably on that note, we'll leave it there then, Basil. Is that okay? And we'll have questions.
Yeah, that's absolutely fine. So,
we'll acknowledge all the various people that are involved with Sheffield bone marrow transplant and neurology, neurosciences departments and institutes and so on, and our collaborators in the last slide. I think that's fine. And yeah. So any questions there?
Okay, thank you very much, John. Should the patient who go abroad to have HSCT for MS out of the NHS be referred to a local transplant unit, as most DPH do not have this? John, do you want to take that?
Well, I personally think that they should. It's kind of an ethical thing, because it's in my experience, patients are vulnerable, and they might have been advised against taking these things into their own hands, and often spending a lot of money, but sometimes they're desperate, or sometimes the relationship's broken down between them and the neurologist or even the GP. It doesn't mean that down the line they should be denied any care or any special input from haematology departments. It's probably better to have a link with a local haematology department, because they will know what the setup is for transplant units is, and ideally these patients should be under a transplant program. But you're probably better off being under a haematologist that knows what the patient's been through than the patient just pitching up with either their GP or A&E, because that's the alternative. They're only going to come in through A&E, and so it's a difficult one, because patients are coming. It's about the one procedure where patients are being treated very intensively, hours and hours and miles away, and there is no, in my experience, no substantive follow-up or means of shared care. It's fine to have treatment overseas sometimes, but there's often very careful shared care programs. So our view in Sheffield would be that we shouldn't be too judgmental on these types of patients. You need to treat their problem at the time.
The other thing to say, John, is that many patients come from abroad, having received the treatments with really specific regimens, expecting that to be followed, like receiving rituximab, for instance, regularly, and that cannot obviously be acted on. But certainly those patients, we Sheffield take these patients into our MS transplant clinic and look after them. The second question is, do we think that it would be appropriate, when do you think it would be appropriate to start the transplant again? Because there might be a second peak sometime next winter.
That's a good point. I guess it's. I think we need to get ourselves through this pandemic, which was going to be well into the summer, and I think we need to take further advice. I think by the time that we're into the summer, we'll be so much wiser than we were, than we are at the moment, and we'll have a better handle on what the best approach is, and whether a second peak can be predicted. I guess a second peak might happen if we've had a lot of people isolated who haven't become infected and thereby immunised. And everything relaxes. So, but at this stage, I don't know really. So I think we've got to bear this in mind, because we want our NIHR trial that is for the whole of the country to be as safely provided and to run as effectively and smoothly as possible. So we'll need to decide when to open that, but I think it's about watch this space, and we'll have to look at the mathematical modelling or other information that comes through. So I think we've got to be cautious, and we'll decide later on in the year. But certainly we won't be running into anything in the next 3 months, I think.
The second question is really, if a patient were to experience a relapse after receiving stem cell transplantation, what would be the DMT option in this case? Well, perhaps I'll take that. Well, until recently, our colleagues in Sweden used to use ocrelizumab for those patients. It was really quite clear really of how to treat these patients, because we've really not had a lot of relapses, but the treatment's been used in Sweden for a longer period of time. And ocrelizumab is being quite effective on those patients. Really, the illness was controlled. We cannot do that anymore. So I suppose if patients, the tricky really issue that those patients may have failed many of these DMTs in the past, but I suppose if those patients have not failed natalizumab, they could use natalizumab. Otherwise, we have to follow the advice, the ABN advice, and use perhaps dimethyl fumarate or fingolimod, and if they can be used, if we fulfill the criteria for that. So that's my answer. My question is a question to Professor Giovinoni as to the HSC community show of data of secondaries malignancies. Well, I think we have to leave that in that case to Professor Giovinoni. Okay, that's fine. That's fine.
Well, I can answer some of that to some extent. I think it's a consequence of any chemotherapy and a transplant included, that you do get usually a low but a predictable rate of secondary neoplasia, and I think that it's often skin cancers, which I guess are usually quite easily handled and good prognosis. You can get myelodysplastic syndrome in a small number of patients that have been heavily treated with chemotherapy, and I guess there's a range of other things, but it mainly tends to be skin, and it tends to be myelodysplastic syndrome. I think I'm not really. I think it's going to be a very low rate in MS. I mean, you're going to have a background population rate of cancer anyway. I've not heard of so many cases of MS patients developing severe complications. Admittedly, the analyses haven't been in thousands and thousands, because I think you need that level of data to make accurate statements. But I think another reason why you should have a lesser rate is that patients with MS haven't really had chemotherapy type treatments on the whole, apart from mitoxantrone in some patients. So I think the risk is going to be low. I think it should be recognised. This is why we need late effects clinics to cover all transplant patients, but they should include MS patients. We have that in Sheffield. It's what we call a late effect clinic, and patients are screened for all sorts of late pathology, even if it's not apparent. The endocrine pathology tends to be one of the more prevalent things like hypothyroidism. You want to correct any hormone deficiency in gonadal failure, with HRT or likewise in males and females. But amongst that, there will be sort of the potential to screen, at least clinically, for various cancers through questionnaires. So those patients should go into that system, and in that way we'll find out what the true rate is. I think it's going to be low, but you can pick these things up quite early, and we in that way we do things as safely as possible. It's also a good argument for patients to be on a large randomized controlled clinical trial, because then you would look at the relative risk between the control arm, and also patients are properly screened and documented for any sort of late adverse event. So I don't think it's going to be very high in and you can put that as well to Professor Giovanoni, who probably mentioned that very, very rarely there have been EBV-driven post-transplant lymphoproliferative diseases. So very rarely in this context we do look out for that. We check EBV PCR levels weekly for the first 3 months, but again, those are the features of immunosuppressed patients in general.
There's another question that's come in actually on the chat screen. Where are the statistics about the link between immunodeficiency and sensitivity to COVID-19 is one of the questions.
I don't know the answer to that. We're learning about this. We don't have data. We're learning as we go. And I don't know the answer. I don't know how to answer that. John, can you answer it at all?
Yeah, I don't think there's so many statistics yet. I think we do know that, for example, there was some data in the Lancet that cancer patients had 3 times the risk of death in intensive care. That was from China. But really, I think we're going to have to wait for all that to come through and be analysed. There's a bit of a lag phase before everything gets analysed. But it's probably true that we're sending out a lot of letters to patients across the NHS for all sorts of immunosuppression, not just transplants, but for any DMT, for any anti-rheumatic agent, and so on. So lots of things are going out to lots of patients. They're not underpinned by large amounts of data. That makes common sense, though. The immunosuppressed patients who also have disability and other problems frequently are more screened, shielded, etc.
Very good. Well, in that case, I hope that what we've done has been helpful to whoever really is on the other end. And I suppose if you have any other questions, then perhaps John and I might try to answer them. But as you know, really, it's a very busy time in the NHS now. So we'll do our best, but we might not be able to answer those really stuff in a very prompt manner.